Good evening, everyone. Thank you for showing up and attending this preclinical medicine revision lecture, the second last of this year. In case you do not know who I am, I'm Alex Todang, a second year Melbourne med student at the Epworth Clinical Hospital. I just want to quickly thank Dr. Lin and Jason Dong for allowing me to use and adapt their slides accordingly. And before we begin, I would like to kind of acknowledge the traditional custodians of the land on which I present this revision lecture on, the Wurundjeri people of the Kulin Nations, and also acknowledge any other kind of traditional custodian groups on which you listen to or participate on as well. Pay my respects to elders past, present, and those who will come to be, who may be attending this lecture or reviewing this lecture later on. I'd also like to acknowledge that the land has never been ceded, and this will always be Aboriginal land. And as an international student, I want to pay my personal thanks to the traditional owners of the lands for taking care of Australia in general and enabling it to be a place where I and other students can pursue our professional and personal dreams. So this is part of a few lecture series that is to raise monies for Asylum Seekers Resource Centers. And for additional housekeeping, I think the internet is good now, but if for whatever reason we have a lot more people coming in, I would appreciate if everyone keep their cameras and microphones off, unless, of course, you have any questions. So feel free to pop questions in the chat as well. And as always, these lectures will be made recorded and be made available on YouTube. And those who have registered via the Tribe Booking will get a copy of the lecture slides as well. So without further ado, let's begin. So generally, we'll just not go that much in depth with regards to endocrinology, but just some things that I feel like are important to at least think about with regards to the foundational and didactic stuff with regards to endocrinology. So thinking about the, it's the Teaching for Impact YouTube channel, Victor. You can look it up later. I'll send you a link after this. But essentially, when thinking about the endocrine system, you really need to think of it out of three levels, essentially: the hypothalamus, the sort of the anterior pituitary, and the target endocrine organs. And that's because at those kind of three levels of, I guess, primary, secondary, and tertiary respectively, that's how they kind of coordinate and feedback towards each other with regards to toning down or increasing the sort of physiological effect of something because the overall effects of endocrine compared to, say, like the nervous system, they take a lot longer to actually, come about, as in to reach their kind of peak effect. But as a result of that, they last for much longer compared to like the effects of a neurotransmitter or other kind of neurobiological chemical communications within the body. And this is just kind of flat peg is a mnemonic that you can use to think about the various anterior pituitary endocrine hormones to note. We'll talk about some of them today, and the rest will be saved for the reproductive preclinical revision lecture. So hello, Connie. Thank you for joining us. Just starting the endocrine revision lecture and just talking about the axis in general. So moving on, let's talk about the thyroid a little bit. So the thyroid is located at the C5-T1 vertebral level, and it consists of the left and right lobes separated by a thin isthmus layer kind of anchoring it to the thyroid cartilage. And also think about the various kind of vasculature, lymphatics, and nerves kind of supplying it. So in terms of the arteries, you're thinking about the superior and inferior thyroid arteries, as well as the EMA artery. And the EMA artery is present in about 10% of people. And if present, it supplies the isthmus of the thyroid gland, but it's also a potential thing for ENT surgeons to look for with regards to potential risks of bleeding perioperatively. When you think about the veins, you need to think about their kind of venous sort of drainage, so to speak. So you think about the superior and middle veins draining into the internal jugular veins on the left and right side, and the inferior kind of thyroid veins draining into the brachiocephalic veins on the left and right side as well. In terms of all the lymphatics, and the lymph nodes are important to kind of examine for on a thyroid / head and neck examination as you kind of go, the pre-auricular, post-auricular, occipital, mental, posterior, anterior triangles and things like that. But they all drain towards the thoracic duct on the sort of the upper left side of the body. And there are various sympathetic ganglia to keep in mind with regards to the thyroid as well. So moving on, we need to think about some of the sort of relevant clinical anatomy as well. So if you're coming into surgery rotation, or if you have a chance to spend time with the ENT surgeon, the main thing that kind of complication, but something that can be easily reversible and addressed if notified promptly, is a hematoma in the neck, usually kind of in the anterior aspect of the neck within the fascial layers itself. So perhaps the surgeon performed like the hemothyroidectomy, or just wanted to get rid of some other kind of abnormal masses or collections within the neck. And then then sometime afterwards, the surgeon gets called that there is some swelling. And the problem with that kind of sort of hematoma is that it's actually physically pushing against and restricting the airway. So that's the reason why it's more of a surgical post-op kind of complication, which one would explain to the patients before they go into theater for the ENT surgery. And then as a result, they would just drain the excess blood fluid and then just monitor that accordingly. As with other kind of risks of complications of operations, you need to think about infection. You think about injuries and presentations of injuries to the nearby anatomy, such as the recurrent laryngeal nerve, particularly on the right side, which can affect the voice, hoarseness of the voice due to the lesions affecting the nerves supplying the intrinsic muscles of the larynx, as well as also injuries to the superior laryngeal nerves, which would, if happen, would cause weakening of the cricothyroid muscles and also the inability for the vocal cords to relax and lengthen. Hypoparathyroidism and hypothyroidism due to the endocrine kind of target glands within the area of an ENT operation are something to kind of keep in mind, particularly with a complete thyroidectomy, because you only need 1 out of 4 parathyroid glands for it to physiologically supply its function. But the effects of an absent parathyroid gland, so if you were to lose all 4, would be more immediate and felt within minutes compared to, say, if you were to do a complete thyroidectomy and one were to feel the effects of hypothyroidism as a result of that. Another thing to keep in mind is a thyroid storm, a thyrotoxic storm, which is essentially a hyperthyroid crisis, so to speak. So obviously you would have the effects of hyperthyroidism. Usually it's a consequence of unaddressed hyperthyroidism that progress to a thyroid storm, and the mortality is about 30 to 50% if not addressed and diagnosed promptly. So not wanting to go too much into the histology of the thyroid glands itself, but just to give the bread and butter facts here, the functional unit of a thyroid gland is, welcome Karina, just talking about the thyroid gland histology now, is that we are talking about the functional unit of the thyroid gland, which is the follicle, which itself is circumscribed by a single layer of polarized epithelial cells, each of them filled with colloid. And the colloid is essentially a solution predominantly consisting of glycoprotein and thyroglobulin. So when it's active, when the thyroid gland is active, there are less colloid, the follicles are small, and the cells are more in their cuboid or columnar shape. And that is because when it's active, the colloid is being actively reabsorbed into thyroid cells, which can be visualized within the reabsorption lacunae. But if they're inactive, so they're not being stimulated to produce thyroid hormone, colloid is more abundant, follicles are large, and the cells are essentially squamous or flat. So, so obviously thyroid hormone is the primary hormone of, the thyroid gland. But does anyone want to either chat or say which of them is either more active or more longer lasting?
Don't be shy. Don't be shy. There's only like 3 of you.
Victor, you should probably know this because endocrine block wasn't that long ago.
So sorry. Yeah, I'm going to go with T4 as well. Okay,
so T4 is the longer lasting one because it's not as biologically active as T3. And you need to have kind of T4 within the peripheral circulation because because you want to have it ready to be deiodinized so that it becomes the more active T3, which in turn will lead to its kind of thyroid sequelae, so to speak. But you don't need to know this, but the T3, the triiodothyronine, is formed from the combination of monoiodothyronine and diiodothyronine, and T4 is just 2 of the diiodothyronines. It's a little bit of excess biochemistry knowledge there. But in the majority of developed countries, the main issue for a hypothyroidism is essentially a low salt, particularly a low iodinized salt intake. Another reason is if someone were to come up from like a high altitude climate where it's not that easy for salt to kind of mineralize and be kind of available for everyone to ingest. Because you need to have that iodine to form the thyroid hormone, essentially. Other things to kind of keep in mind is that, as mentioned before, colloid is the way it is because it is a biochemical reservoir of thyroid hormones. But for a human to particularly become like clinically low in iodine to present symptomatically, they have to be completely free of iodine in their diet for pretty much a couple of months before you visually see a decrease in thyroid hormone levels. And if you mentioned earlier, if you recall just what I said earlier, a hypothyroidism would take quite a long time for it to clinically manifest compared to, say, a hypoparathyroidism. All right, so even with regards to dietary iodine, about 1/5 of them would actually enter the iodine and 4/5 of them would be actually excreted in the urine because out of all the iodines we intake, we actually don't need that much relative iodine to make the thyroid hormone per se. And similar to other ways that iodine enters the thyroid cells, sorry, how the thyroid cell transporters work. It works by a symporter that transports 2 sodium ions and 1 iodine ion into the cell with each kind of cycle of thyroid hormone production. So moving on. So this is the essential steps with regards to the synthesis of thyroid. Just a few facts to highlight here. The TPO is actually membrane bound within the thyroid cell, And the TPO is the actual enzyme that oxidizes iodine and catalyzes the coupling reactions where like the mono and the diiodothyronine units become T3, and the diiodo and the diiodo becomes T4. And when the actual thyroglobulin gets internalized within the thyroid cells, it's directed towards the lysosomal degradation to form the actual final product of T3 and T4. And everything else that is not used to make the final T3 and T4 pretty much gets stored and or recycled. So just in the interest of time, the three kind of transport proteins for T3 and T4 would include albumin, which is like the transport protein for a variety of things in general, thyroxine, transthyretin, and TBG, thyroxine binding globulin. And so why they need to be bound? So does anybody want to answer why they need these chaperone proteins, so to speak? So in essence, it has to deal with their relative biochemistry again. So T3 and T4 are inherently lipophilic, as in they dig the fat and the non-polar, but obviously blood is mostly polar, or at times a sort of like a salt kind of a solution, so to speak. So as a result, they need the proteins, which are naturally charged, but they can carry these fat-loving kind of T3 and T4 within the actual circulation, so to speak. So anything else? So obviously, relatively speaking, albumin is the most abundant compared to transthyretin or TBG. But obviously TBG is the more tightly specific or affinity with thyroid hormone, and albumin being the least affinity because it's like the jack of all trades kind of chaperone proteins. All right, so this is going into further detail with regards to the effects of thyroid hormone. And when T4 and T3 kind of become secreted or reaches their target tissues, it has a multi-organ effect on the on other kind of endocrine kind of pathways, on the heart rate, on the breathing rate, on the metabolic kind of status of the human body as well. So when you think of hyper versus hypothyroidism, the TLDR is that the hyperthyroidism would cause an excess or a hypermetabolic state within the body. So everything becomes, excess. So like you feel more agitated, you feel more on edge, you feel more tremors, you may feel palpitations, you may to the point of having an arrhythmia in the form of atrial fibrillation. You feel thin, you may appear thin, but not to the point of being cachexic. You would break through your energy source quite quickly just because of how high your metabolism is. And also your blood pressure would go up, and everything pretty much would be in reverse with regards to hypothyroidism. So slow mentation, hyporeflexia, constipation, and hypothyroidism, in case you are suspecting an endocrine case or endocrine causality with regards to the patient's presenting complaint. If you want to go into more details with regards to the metabolism of hyperthyroidism, muscle weakness because of how excessively the proteins are being broken down. Whereas in hypo, it'll be cramps and stiffness. And as a result, even though there may be muscle weakness in both hyper and hypo, the sort of pathological causes to why is a bit different. So primary, secondary, and tertiary kind of refers to the level at either at the target tissue, which is in this case the thyroid gland, the secondary tissue, which is in this case the anterior pituitary, and the tertiary, which is essentially the hypothalamus. So just out of kind of like, the interest of time, you can kind of fill out on this table alone, but would anyone kind of like to volunteer for, say, a cause and sort of like the table readings for a primary kind of hyperthyroidism? All right, so obviously one of the causes of primary hyperthyroidism, at least in Australia, is Graves' disease. So, which is due to an autoimmune reason. A lot of T3 and T4 is being produced because the antibodies are similar in shape to the actual thyroid stimulating hormone, and as a result, they bind to the receptors on the thyroid gland, and causes an excess production of T3 and T4. So in this case, a bunch of a primary T3, T4 would be high, TSH would be low because it would actually try to combat some of the effects, but not to little effect because the antibodies is kind of acting like TSH. And similarly, TRH, depending on whether it's acute, subacute, or chronic, would be either normal or more likely to be low as well. Okay, so let's move on, so to speak. And this is just kind of seeing the relative kind of acute, subacute, kind of, or in this case, preclinical or clinical timelines with regards to free thyroid hormones, as well as to the stimulating hormone in the context of hyper versus hypothyroidism. And notice how it's kind of the inverse of one another. So this is just like a list with regards to some of the common as well as some of the serious causes of a hypo versus a hyperthyroidism, which I'll leave it to you to kind of study on your own time. But let's go through some of the clinical important questions. So what are some drugs that can be used to treat hyperthyroidism? Yep, good job, Connie. Carbamazole, which is an example of a thionamide. Then there's another class of drugs called sort of like the it's like PTU, propylthiouracil, which is also another thionamide, is another example. But essentially how they function is to inhibit the TPO, the thyroid peroxidase enzyme, but also the propylthiouracil, or PTU, also works in the peripheral circulation by preventing that T4 conversion to the active T3. So at least with regards to a patient that's pregnant, you would be careful to use carbimazole because it is a teratogen. So therefore, PTU, or propylthiouracil, would be used within the first trimester. But in the second or third, you can switch back to carbimazole because PTU itself is also known to be hepatotoxic, so very dangerous to the liver. So it's a bit of a balancing act with regards to the treatment of thyroid there. So then moving on, we'll just move on to the next system, which is the adrenals. So these are glands that are located within the superior aspect of the kidneys, enclosed by the renal fascia, and which is themselves attached to the crura of the diaphragm. However, they are not continuous with the kidneys because they are separated by fibrous tissue. So on the right side, you'll notice that the suprarenal or the adrenal gland is pyramid shaped as it makes contact with the IVC anteromedially and the liver anterolaterally, whereas on the left side is more of a crescent moon shape because it's more intimately related to the spleen, stomach, pancreas, and left crus of the diaphragm. As one would surmise, the arterial supply to the suprarenal glands are the superior suprarenal arteries, and also the venous drainage would be the suprarenal veins. So this is just the histology with regards to the layers and what they produce. So obviously you may have countered this mnemonic with regards to which layer and what kind of sort of hormone or substance produces. So it's like the deeper it goes, the sweeter it feels. So glomerulosa, salty, fasciculata, sweet, and reticularis, well, for sex, and I guess chromafins is, I guess your sort of drug addiction thing. So this is the steroid kind of synthesis mechanism, because you need hydroxylase as well as aromatase to actually engage into the conversion of sex hormones or steroid hormones to do various things, though they could also be interchanged between androgens and glucocorticoids and mineralocorticoids respectively. So if you were to think about a deficiency in the alpha hydroxylase enzyme, you would actually have a hyperaldosteronism. If you have a 21 hydroxylase deficiency, you would have no aldosterone. If you were to have a deficiency in 11 beta hydroxylase, you would have no aldosterone, no cortisol, and excess amounts of sex hormones being produced. So this is more of the mnemonic with regards to the effects of cortisol, which is your glucocorticoids or your stress hormone. Its effect on increasing appetite, increasing blood pressure, promoting insulin resistance, promoting some essentially the gluconeogen. So basically synergistic with the effects of insulin with regards to gluconeogenesis, lipolysis, proteolysis, as well as fibroblast activity. Let's see, it reduces inflammatory effects. Well, you know, steroids are known to reduce inflammatory effects. And bone formation, it also, with regards to cortisol, as one would think of excess stores in the body, it's actually bone destructive. And as a result, it reduces osteoblast activity due to affecting the rank L ligand and OPG kind of balance, where rank L ligand is in the excess, promoting osteoblast reduction and osteoclast activity. So this is just some cortisol regulation from one of the medical pharmacology textbooks. That's something to kind of read up on your own time or to review. So Cushing's syndrome, as opposed to Cushing's disease, is the more general aspect of having excess corticosteroids within the body. And as a result, it results in a primary adrenal adenoma, a hyperplasia, or a carcinoma. The carcinoma more in the context of the Cushing's disease in that case, where it's a primary tumor, so to speak, an ACTH secreting pituitary adenoma. Sorry, this would be a secondary tumor in this case. But you can also have the effects of paraneoplastic syndrome as well, due to some carcinoids and small cell lung cancer as well. So this is a general mnemonic with regards to Cushing's syndrome. So the central obesity, collagen weakness, comedones, cortisol being free in the urine and increasing glucose being produced in the body, straight on physical examination in the abdomen, reduced immune function, a bunch of hypers in terms of steroids, in terms of blood pressure, sugars, and cholesterol, and yeah, other kind of effects with regards to Cushing's syndrome. These are the general investigations that one would order. So going into more detail about them, you want to do these tests because with regards to how the nature of endocrine physiology is more chronic and longer lasting, the effects of a endocrine-based pathology or disease is also kind of subclinical, as in you would need to follow the patient's sort of readings and history over a course of period of time to really piece it together what exactly is going on. In the case of a hypofunctioning gland, you would need to stimulate it. And conversely, in the case of an overactive gland, you would need to suppress it. So with regards to Cushing's, again, it depends on it, whether it being a primary, secondary, or tertiary cause. And sometimes you can just treat it with some steroids. Sometimes it can just be as easy as actually removing the masses itself in the case of a hyperfunctioning or hyper-producing mass. But then you would have to kind of monitor them afterwards with regards to potential hormone replacement therapy, as well as some lifestyle modifications, and also be aware of the 1 in 4 chance of recurrence within a decade of follow-up. And with regards to adrenal insufficiency, again, it's obviously represented by a reduction in the adrenocortical hormones being produced. It can be, again, classified by either being primary. In the case, it will be referred to as an Addison's disease of the adrenal glands, or it can be due to a secondary or tertiary due to pituitary or hypothalamic involvement. So this is just the general kind of clinical presentation of an Addison's disease, which can be either acute or chronic. And obviously similar to if a thyroid excess is left undetected and let to kind of run wild over time, with an adrenal kind of thing, and Addison's disease, it can lead to something called an Addisonian crisis. So you have this plethora of clinical presentations here. Most notably the abdominal pain, weakness, weight loss, fatigue, low blood pressure, and particularly the craving for salt and hyperpigmentation of the skin. So in order for adrenal insufficiency to present itself kind of clinically, 90% of the adrenal cortex itself needs to be destroyed or non-functional. Particularly, it starts off and it's the destruction of the zona glomerulosa, the most kind of external histological layer of the adrenal glands itself, which leads to obviously reduced salt and water retention. So RAS system would try to address it, but again, to limited effect. But essentially the patients will be perpetually thirsty, and they would also suffer from the effects of a hyperkalemia, as one would see on ECG, so to speak. And obviously more other effects due to low cortisol as well. So again, this is just kind of going back to the Addison's disease kind of investigation algorithm, whether or not the cortisol says something, or whether or not it is due to an adrenal gland issue as well. So this is another diagnostic test that you can do, which is the Synaptin stimulation test. So essentially you are stimulating the suprarenal glands to see whether or not they respond to a synthetic analog of adrenocorticotropic hormone. And you need to measure again over a period of time at 0 minutes to an hour later. And obviously if everything is all okay in terms of physiology, it would be acutely kind of elevated and then it will plateau a little bit. But if the actual adrenal insufficiency is significant, then they would have barely anything change. So with regards to an Addison's disease, it's usually lifelong glucocorticoid replacement therapy. And there are various kinds of cortisone or steroid drugs to use to treat it. But obviously with regards to using steroids, you need to think about the possible side effects of lifelong steroid therapy, particularly if it's like a high dose steroid therapy. So you want to think about the risk of osteoporosis. You possibly want to think about immunosuppression. You want to think about the also the effect of a iatrogenic Cushing's as well. So obviously some of these doses would have to be weaned and adjusted accordingly over the course of the patient's lifetime management. So to prevent adrenal crises, some basic bread and butter things were to wear like a medical alert bracelet, so that regardless of where you are, the hospital will have a general idea that this patient has a history of poor adrenal function, and that's to also let them know whether or not they should really get into using steroids. You need to use some steroids prior to any kind of physical exercise. Steroids would have to also be used in the case of some kind of pyretic or sort of traumatic kind of stress. And also need to have some syringes and injections on hand if necessary, whether for the patient themselves to carry or for the actual kind of hospital or other environment to keep in mind as well. Last but not least, always let your dentist or other people that you see know with regards to your lifelong use of steroids. So this is more of the physiological kind of aldosterone sort of circulatory pathway. But essentially, it is due to aldosterone now having its effect to try to promote water reabsorption, which in turn is promoting sodium reabsorption, which in turn helps to retain as much blood volume as possible and to make sure blood pressure does not decrease as accordingly. So with regards to a primary hyperaldosteronism, so Akan syndrome, it's one of those things where it is, I wouldn't say medically refractant, but basically it is still resistant to sort of like your first line medications used with to treat high blood pressure, sort of like ACE inhibitors, beta blockers, and also a noticeable hypokalemia as well due to the excess kind of potassium being excreted with urination. Another thing to kind of think about is a pheochromocytoma, which is a catecholamine excessively producing tumor, specifically secreting epinephrine, norepinephrine, and dopamine. So it comes in episodes of symptomatology in terms of high blood pressure, pain, clamminess, palpitations, and pallor. So that's its own kind of 5 Ps. And you also need to think about the rule of tens with regards to its symptomatic presentation, which is 10% malignancy, 10% bilateral, as it affects kind of both tumors in both suprarenal areas. It could also be 10% in the outside of the adrenal glands, 10% risk to lead to calcific kind of lesions and complications, and also 10% of it to occur within children. And also to address a pheochromocytoma before it leads to an actual crisis, you would need to do an alpha blockade before beta blockade by the use of a drug called phenoxybenzamine. So last but not least, let's just go into the endocrine aspects of the pancreas. So just to review about some stuff, possibly from the gastrointestinal lecture taught by Sean and Reese, the pancreas has aspects that is intraperitoneal as well as retroperitoneal. So the retroperitoneal aspects, so the one that's more posterior, is the one that actually merges and feeds into the duodenum. And it's actually the pancreas that actually, the duodenum itself, because of its relative kind of proximity to the pancreas, is at risk of cancer. The head of the pancreas as the expanded part of the gland, which is embraced by the curvature, the C shape of the duodenum. The uncinate process is a projection of the pancreatic gland from the inferior part of the head that extends immediately to the left, posterior to the superior mesenteric artery. The neck of the pancreas overlies the superior mesenteric artery and other vessels. It is also the origin of the hepatic portal vein, which itself has a groove that is in its posterior aspect. And the body of the pancreas continues from the neck and lies to the left of the superior mesenteric artery and superior mesenteric vein, anterior to the splenic vein. And the last bit, the tail, is the one that's kind of feeding into the hilum of the spleen and also anatomically connected with the left colic flexure. So this is going into details with regards to the pancreatic blood supply. And I guess this is just kind of something to kind of think about as the consequence of a portal hypertension, leading to, which could be backed up into the splenic vasculature, which if also gets obstructed and backed up can lead into the pancreatic vasculature. The TLDR is the pancreatic arteries derived primarily from the branches from the splenic artery, and the superior and inferior pancreaticoduodenal arteries supply the head of the pancreas. And the pancreas itself, the vasculature of the pancreas itself, the veins, mostly drains into the splenic vein, though the pancreatic head drains into the hepatic portal vein. So this is the histological kind of arrangement from this cross-section of the pancreas. So alpha cells are mostly associated with glucagon, and it's located in the periphery of the pancreas. The beta cells, also located peripherally, is the one that's more associated with insulin, is the one that gets targeted by antibodies in the case of type 1 diabetes. Delta cells are the ones that are randomly distributed towards the pancreas. It's more involved with the production and release of somatostatins. So Cpeptides, just know that it is a immunoassay kind of task, and it's the reason for it is because Cpeptides is the clear byproduct of insulin production, and that with Cpeptides, it's more indicated for patients with recurrent hypoglycemic episodes, like for those with type 1 diabetes. And obviously, you would use it in the case of diagnosing also insulin secreting tumors, insulinomas as well, if C-peptides were to be increased. But there can be various reasons for kind of C-peptides to be increased as well. So this is insulin secretion, which is the main sort of catabolic kind of hormone, whereas glucagon is more of an anabolic hormone. And obviously the main regulator of insulin release is glucose. And also there is increased insulin response due to oral glucose versus IV glucose due to the presence of something called incretins, which is essentially referred to as glucose-like protein 1, where it causes glucose to enter the cells, and which promotes the ATP production, which in turn promotes the closure of ATP-sensitive potassium channels, which in turn leads to the depolarization of the beta cellular membrane, which in turn leads to stimulation and opening of calcium voltage gated channels, leading to calcium being transported inside the cell, which in turn leads to the increased release of insulin outside of the cells into the bloodstream, so on and so forth. So GLUT1, the glucose transporter 1, is located in red blood cells, brain, cornea, and placenta. Transport 2, beta islet cells, liver, kidney, and gastrointestinal tract. 3, the brain, placenta. GLUT4, particularly important with regards to muscles, in striated muscle cells and adipose tissue. And it's the one out of them that is insulin dependent, i.e. it depends on insulin to be at a certain level for it to, function. And it's also associated with the muscles, because muscles are really metabolically active and they would need to have they would want to stimulate increase in GLUT4 in order to get that aerobic energy to them first before obviously relying to the anaerobic lactic acid fermentation and so on and so forth. GLUT5 is more of a fructose transporter rather than a glucose transporter, but it's mainly found in the gastrointestinal tract as well as spermatocytes. The steroid effects of glucose, if you were to recall the stress hormone or cortisol or glucocorticoids in general, it is essentially to synergize with and enhance the sort of catabolic effects of insulin, so to speak, because you want to promote that increase in energy, particularly in the case of stress. Ideally in acute stress, obviously not for chronic stress, which is kind of another topic in and of itself. So this is just going into more of the details with regards to different states with regards to insulin as well as glucose within the body. And these are kind of the diagnostic tests as well. So we already talked about the C-peptides before, but now that we're talking about hemoglobin A1C, and the reason why we want to talk about hemoglobin A1C is because it's particularly indicative, particularly for diabetic patients, to see how well their glucose is controlled. And the reason why that's the case is because with regards to sugar, it causes the hemoglobin within red blood cells to be permanently glycosylated. And just to keep in mind, there are various reasons why HbA1c can be increased, aside from obviously just increased glucose. So it can be increased in the case of an iron or vitamin B12 deficiency, or not a lot of red blood cells are being produced. It can be due to some genetic or chemical alterations of hemoglobin. It can be due to the increased glycation due to alcoholism, chronic renal failure, decreased intraerythrocyte pH, or just the red blood cells being actively, decrease as well. So the red blood cell population decrease as well. Other things that can affect the HbA1c readings, aside from alcohol, bilirubin as well in the case of jaundice, whether it's iatrogenic or pathological jaundice, and so on and so forth. So obviously with regards to type 2 diabetes, it may seem kind of obvious, like cut down the sugar, use metformin, lifestyle modification. One useful mnemonic to kind of help with this is something called SNAP, which regards to smoking cessation, if the patients are actively smoking. Nutrition, so refer to some dietitians to see what kind of diets that they would suggest, such as the Mediterranean diet or the DASH diet, as it's becoming more and more popular. Obviously, toning down the alcohol intake to the typical 2 standards or less per day, and also promoting physical activity as well. So these are the various kind of pharmacological kind of managements with regards to diabetes. Some of them more for diabetes type 2 than for type 1. Metformin, your biguanide, is your go-to kind of first line kind of management. Sometimes you may require something a bit more potent like Giardet. And obviously, if metformin doesn't seem to really help, then you would consider the oral hypoglycemics as well. Or you would also consider the actual glucose transporters themselves. But with regards to glucose transporters, SGLT2 inhibitors are loved by renal physicians, nephrologists, because of how sort of it helps with regards to maintain as much of the impaired renal function as possible. But obviously with regards to any kind of drugs, there are good and bad effects to any and all of them. Macrovascular is more of the cardiovascular risk factors and stuff. Microvascular refers to the eyes and the peripheral neurovascular pathologies. Diabetic ketoacidosis and the hyperosmotic state in HSS, and obviously a hypo incident, particularly for type 1 diabetes. So with regards to monitoring and prevention of diabetic complications, you want to reduce all the vasculopathic risk factors, because definitely a heart attack would be a fatal and common complication of diabetes if it is not addressed. You'd also want to address issues of immunosuppression as a result of the diabetes, such as getting a tetanus booster at the age of 50. You want to make sure blood pressure is optimal so that it is protective for not just the heart, but also for the kidneys as well, because remember that the heart and the kidneys are connected in series. Also, consult with a multidisciplinary team so that they are actively involved with the patient's management. So aside from the general practitioner to look at your blood sugar levels and HbA1c to make sure that the blood glucose is being controlled, assess renal functions with nephrologists, assess visual kind of functions with ophthalmologists, and as well as potentially an optometrist if some eyewear needs to be ordered. Obviously, some of the retinopathies or ocular pathologies would be some macular degenerations and glaucomas. And with regards to diabetic neuropathy or vascular pathology, neurologists to see how much of the peripheral sensation, particularly in the feet, have been lost. A vascular surgeon, especially if there are to be some diabetic ulcers, some podiatrists as well. And also, you may also want to consider consulting with an orthopedic surgeon or rheumatologist if in the case of charcot foot or charcot joint, which is essentially due to undetected microfractures as a result of the reduced sensory detection, and as a result, which would lead to also an inflammatory destruction and permanent changes to the foot, causing it to lose its natural arch. Obviously, you want to look about the associated conditions of diabetes, such as depression, OSA, and just metabolic syndrome as well, like obesity, and also erectile dysfunction as well. So with a diabetic ketoacidosis, it's one of the causes for a metabolic acidosis. You can refer to this kind of diagram here, but essentially what happens is due to the tendency to oxidize excess kind of sugars and fatty acids, which is now more present within the body, it leads to the accumulation and sort of oxidation to ketone bodies. And as a result of those ketone bodies accumulating, it leads to the ketoacidosis. And as a result of that, that could lead to, that can occur to cause, or it can occur at the same time as a hyperglycemia, all because of insulin not being produced, most likely due to the destruction and reduction of the pancreatic beta cells. So with regards to diabetic ketoacidosis, it is an emergency. So you would need to do your typical arterial blood gases, your full blood examinations, your urine electrolytes, creatinine, to look at the kind of the electrolytes imbalances that is a result of the diabetic ketoacidosis. Also assess the glucose levels within the bodies, and last but not least, serum ketone assay to assess the degree of a diabetic ketoacidosis. So you want to look at blood culture because with increased sugar in the bodies, Obviously, bacteria and other bugs love sugar. So if you have excess sugar in the bodies, that could provide the bugs with a lot of sort of energy to reproduce, which in turn will lead to sort of the negative consequences of infection, and particularly sepsis, which can also be supported with a urine dipstick as well. Chest X-ray to see if there is an active kind of pneumonia changes, and ECG again to kind of confirm the effects of a electrolyte imbalance, such as with potassium. So you would administer normal saline if the patient is markedly dehydrated and low hypotensive. Give insulin via continuous infusion, but also continue with patients regular long-acting insulin at usual doses and times. However, if it's a new onset or new diagnosis of type 1 diabetes, obviously start with insulin stat. You would also want to give potassium, because the potassium, remember potassium and its linkage with glucose with regard to glucose potassium transport. So you would need, so that when insulin is being administered, this would cause the body's own stores of potassium to be excreted out excessively. So that's why you want to give some potassium as well, to make sure that the patient does not go into hypokalemia. And last but not least, want to give some glucose, because glucose levels would correct itself before complete ketone removal from the body. Last but not least, treat the cause of the actual diabetic ketoacidosis. So HHS is a different kind of emergency, which is defined by profound, extensive high blood sugar levels, as well as promoting a hyperosmotic state within the sort of the interstitial blood fluid levels within the inner environment of the human body, which ultimately to reduction and dehydration of the patient in the absence of a ketoacidosis. And it mainly occurs with type 2, whereas DKA primarily occurs with type 1, usually occurring in older people, though it can present a little younger, especially if it's their first kind of real presentation of type 2 diabetes. You would also tend to notice this in diabetic patients who are bedridden and on fluid restrictions due to some other kind of pathology. Here is the Calgary Guide kind of recommendation, sort of diagnostic algorithm for HHS. With regards to emergencies, the adrenergic symptoms, pale skin, sweats, shaking, palpitations, anxiety. Neuroglycopenic symptoms would include hunger, reduced mentation, confusion, coma, seizures. And some of the risk factors for an HHS, aside from just being on fluid restrictions, elderly, bedridden, not moving a lot, insulin therapy, patient being unaware of a hypo or having had a previous instance of a hypoglycemic incident. And to manage the HHS, you would do, if the patient were to be conscious, you would give them some soft drinks, some jelly beans or glycogel, or other kind of high glycemic index foods. If they are unconscious, you would give them some intramuscular glucagon, recheck the glucose if they are still unconscious, and if they are regained conscious, you would eventually want to reduce their food intake to something a bit of a lower glycemic index, such as whole wheat sandwiches and things like that. This is kind of the Teaching for Impact's kind of education experience survey, which if you have your own time, you would scan the QR code just to really spend a few minutes to talk about what worked well, what didn't work well with your regards to your medical education. And last but not least, The final preclinical med revision lecture of the year will be taught in a couple of weeks. And I know that all of you may be feeling stressed, anxious, worried about the end of year assessments, but please, 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 just remember your training. Try to keep things quadruple C, calm, cool, collected, and everything will be copacetic. And if you have any kind of questions, comments, or concerns, or you wish to be involved with Teaching for Impact, please go to the Teaching for Impact website. Again, thank you to Jason and Dr. Victor Lin for letting me use and adapt their slides for this presentation. And whether you have watched this live or watching it as a YouTube recording, I wish each and every one of you all the best. Thank you very much, and have a good evening and good rest of the year.